So, till date, we have completed our cardiovascular system, respiratory system, and burns. Today, we are going to see the nephrourology conditions. So, in nephrourology, we shall look into the anatomy and physiology of these conditions, and then further we'll proceed from here. Okay. So, the kidneys, this is the normal position of the kidney. We have one pair of kidney. There is two kidneys. And the kidneys, we have the renal arteries, the renal vein, the ureter, urinary bladder, and the urethra. The basic anatomy and physiology. So the kidneys, ureter, bladder, and the urethra. This is what it is known as the urinary system, the structure of the urinary system. Okay. So we'll first look into the kidneys. Uh, I'm not going deeper into these anatomies and physiologies, but just for an emphasization and clarification of, it's just a recall of the anatomies. I'm not going into deep. Okay, not into all these muscles and fascias because no questions will be asked from the. So the kidneys are having adrenal glands, or the adrenal glands are otherwise known as suprarenal glands. The anatomy of the kidney. So you just, if you want, you can just take the screenshot of these all things. Okay. So the anatomy of the kidney, in that we have the, see, this is the basic kidney structure. This is the basic kidney structure. In that we are having the renal pelvis. So what is the use of the renal pelvis? It collects the urine which is drained out of the kidney. And renal calculi can be seen in these renal pelvis area. Okay. Stones can be seen in this renal pelvis area. It's a covering. So the outermost covering of the kidney is known as the cortex, and inner area, this is known as the medulla. Okay. Then here are the basic structure of kidney, which is the nephrons. Nephrons are seen in cortex as well as in medulla. Okay. It elongates it. The see This is how the nephrons can be seen. Okay. It is both present in the cortex as well as in the medulla. Okay. And these are known as the calyces. Okay, these are the calyces. So this is the basic structure. And what is renal parenchyma? In the renal parenchyma, we have the cortex and the medulla. These things are known as the medulla, which is clearly known as the pyramids, renal pyramids, and there are renal papillae here. Okay. And the cortex, here we have the cortical arches and the renal columns. Just understand that this is the cortex and this is the medulla. In the medulla, we are having the renal pyramids. So now this is a basic structural and functional unit of the kidney, which is known as the which is known as the nephron. Now we shall see what are these things in here. See, this is the. I believe all of you are very well aware of these nephrons and its functions. So this is the Bowman's capsule. The Bowman's capsule continues as a proximal convoluted tubule, then to the Henle's loop or the loop of Henle. Then it converts, then it connects as the distal convoluted tubule, and then to the collecting duct and the urine flow. Okay. See the Bowman's capsule. This is the main structural area. This is the main structural area of the nephron. So what happens in case of Bowman's capsule? The efferent arteriole. Okay, what do you mean by the efferent arterioles? The renal arteries as well as the renal vein when enters into the kidney. So, suppose this is the kidney and it enters into the kidney. After entering into the kidney, it divides. The arteries will divide, and it will be so divided that it may it continues as the arterioles. These arterioles are known as the efferent arterioles, and these efferent arterioles will enter into these smaller structures of Bowman's capsule. So these will be very microscopic structure. Okay, so this is an artery which entering into this Bowman's capsule. Okay. When it enters into the Bowman's capsule, it will having a it will coil here. Okay. It will coil here like how it is coiled in the intestine. Okay, it will coil here like this. Then what happens? Let me have a let me draw a closer look here. Okay, this is the Bowman's capsule. This is the artery covering here. Okay. So the waste structures, like you can name the the creatinine, the urea, then those are the main waste structures. Then sodium, potassium, calcium, magnesium, even our glucose, protein. The protein means albumin. All these things can be excreted from the woman's capsule. Let me remind you, the pores of the Bowman's capsule are very thin. It is very short or it is very crisp so that it will accommodate only smaller molecule particles. Okay. The glucose and the proteins are larger molecules so that it won't enter into the Bowman's capsule and it won't excrete it through your urine. Why? Glucose is the essential part of the body. The proteins are the essential part of the body so that it won't get excreted through the Bowman's capsule. Fine. So now you can see, in the urine we can see glucose, in the urine we can see albumin. Why this happens? What is the reason for that? See, it is known as a renal threshold. The normal renal threshold is 180 mg per deciliter. When the blood glucose level exceeds these 180 mg per deciliter, then the glucose will be present in the urine. Okay. Why is it so? Because the presence of glucose or the pressure of glucose inside these arterioles will be large. So since it is more than 180 mg per deciliter, it will press the glucose molecules which is entering into the sugar, which is entering into the kidneys. And due to this threshold, or the kidney can only hold the sugar within the blood up to the level of 80 mg per deciliter. After that, it will be pressure out and it will be inside. It will go out of these arteries. Okay, so that is known as a renal threshold. That's why the glucose is present in the sugar. Next condition is, albumin. So why it is present in the albumin? See, in no normal conditions, albumin will be present in the urine. If this albumin is present in the urine, the kidney is compromised. Why kidney is compromised? See, I have already said the pores of these Bowman's capsules are small. In case of glomerulonephritis, pyelonephritis, or in any conditions, any infection to the kidneys, these pores will be compromised. Which means, see, this is a normal pore. Okay, this should be the normal pore. In any glomerulonephritis or any infection to the kidneys, these pores will be having abnormal structures like this. See, when there is such kind of structure, the size of the pores increases. Okay, when the size of the pores increases, the albumin is usually be taken out of the kidney via the urine. Okay, so this is the condition which increases the amount of albumin inside the urine. It may be a glomerulonephritis or pyelonephritis. When albumin is present in the urine, it gives you a frothy urine. Clear. Next is the sodium. See, usually in some conditions, okay, in some conditions, glucose may be excreted from the urine. These albumin will be excreted from the urine if it is a smaller pyelonephritis or if it is in a mild level. The amount of glucose as well as the albumin which is excreted from the urine will be on a minimum scale. Okay, in that condition, what happens is that soon after it is excreted through the Bowman's capsule. See, the efferent arterioles, right? The efferent arterioles have a chain-like structure, a network throughout the nephrons. Okay, when what is the function of that? It will it will reabsorb the excreted substances. So the Bowman, when in the Bowman's capsule, when it enters into the Bowman's capsule, it then moves to the proximal convoluted tubule. So the glucose, your albumin, all these essential and vital things will be absorbed from the proximal convoluted tubule. Okay. In no case the kidney will compromise the excretion of these substances. So the kidney tries to absorb it through your proximal convoluted tubule. If the amount of glucose, if the amount of albumin is so high that when the proximal convoluted tubule is not able to absorb it, then it will be present in the urine. Okay, and so that is about the proximal convoluted tubule. Next is the Henle's loop or the loop of Henle. See, the point here is the Henle's loop will maintain the current and co-current mechanism, which means simply just leave all those physical activities. The sodium, the sodium and potassiums are mainly reabsorbed from this Henle's loop. Okay. Lasix, what is the function of Lasix? It is a loop diuretic, right? So what is a loop diuretic? It affects on this Henle's loop and it increases the excretion of the water. Along with there will be sodium. See, the sodium and potassium effect will be here in the Henle's loop. When the sodium is reabsorbed, potassium won't. When potassium reabsorbed, sodium won't. Okay, so when there is when we give the furosemide or the Lasix, it will act on this Henle's loop and it jitters with the sodium and potassium reabsorptions. Okay. Next is the distal convoluted tubule. Water, the main content of fluid is the urine is water. See that usually it is 97 percentage of water and the 3 percentage of the waste will be there. All these contents of the urine will be 3 percentage. You can say the creatinine and urea, then other excretory waste, then all those things which is present in the urine. It comprises of 3%. So the water which is present in the urine will be reabsorbed from these distal convoluted tubule. You know, when the atmosphere is hot in the summer season, you urinate less, right? In the rainy season, you urinate more. Why? It is because body regulates, the kidney regulates what amount of fluid that your body should be having and what amount of fluid the kidney should be excreting. Right. So that comprises the amount of comprises the amount of fluid that is inserted or excreted from the kidneys. So that part is majorly controlled by these distal convoluted tubule. Right. Next, it goes to the collective duct at the urinary tube. This is a normal function of nephrons. No, see, as I have said, it is there in the cortex as well as in the renal pyramid. So, see, just take the screenshot if you want. So what are the main functions? The things which I have explained, it is here. What's the note of that? Just take a screenshot if you want. Now, composition of your normal urine. See, I have said 97 percentage, or it may be differing. No? See, 96 or 97, no matter. Then 2 percentage of urea will be there. Then bicarbonates, iron, potassium, sodium, chlorine, urea, all the things which the kidney wants to excrete. Okay. Now, the urine description. Okay. A question may come for the prometric examination based on the urine status. What the urine, uh, what you have to check in the urine. Don't consider that it is for a question from the foundations of nursing, but it is from the uro nursing. Urine description. The normal, see, this thing is super important. What is the normal urine excretion? It is 30 ml per hour. Okay. The urine excreted from the body is 30 ml per hour. This is the minimum urine output that a body should possess, 30 ml in an hour. Okay, when catheter is, when you are understanding it is less than 30 ml per hour, you have to check, you have to think that your uh, kidneys are compromised. Okay, that is a normal urine prescription. So the amount is 1.5 liters per day. In a day, it will be 1.5 liters. Okay, that is the normal urine description, 30 ml per hour. Then color, it is color is light to dark amber and it is aromatic odor. The specific gravity is 1.005 to 1.030. The pH, it is acidic in nature. It is usually 4.5 to 7.5. The urea, the urea will be the urine will be kind of covering with urea, which is the waste of the protein metabolism. Uric acid as as a result of purine metabolism. Then creatinine as a waste muscle metabolism. It's a protein waste. Abnormal constituents in the urine are glucose. Glucose should not be there in the urine. If glucose is present in that, the renal threshold will be more than 180, which means the blood sugar will be more than 180. When we should see, when a patient is when you receive a patient with 250 mg per deciliter blood glucose level, or any patient who is having an increased amount of glucose, first thing you have to do is you have to check for the urine acetone. Okay. And if the urine acetone is positive, you have to check the patient for its ABG, and you have to check whether there is. See, in diabetic ketoacidosis, what will be the value? Is it a metabolic acidosis? Is it a metabolic alkalosis? Is it a respiratory acidosis, or is it a respiratory alkalosis? Rajesh, what will be the reason?
So can you repeat, sir?
In case of diabetic acidosis, diabetic ketoacidosis, what sort of change you can see? Is it metabolic acidosis, metabolic alkalosis, respiratory acidosis, or respiratory alkalosis?
Mhm. Metabolic disease.
It is metabolic acidosis. In case of diabetic ketoacidosis as well as lactic acidosis, the condition is metabolic acidosis. In diarrhea, vomiting, you may have metabolic alkalosis. Okay. Fine. So those are the conditions. So that's about the glucose. Then when we check the protein, when there is an abnormal presence of protein in the urine, we can see that there is a pyelonephritis or a glomerulonephritis. Why RBC is present in the urine? Because again the kidney have been damaged. Ketones present in bilirubin, calculase, WBCs. All these should be an abnormal constituent. It should not be there. Normally, it should not be there in the urine. Okay, if all these one among these is present in the urine, you can understand there is an abnormality, and you have to check for that. Now, normal order of the urine. It's an amber color. Amber color. It is aromatic order. What are the abnormal orders? We can see. Okay, kindly check this. If the urine is having an ammonia smell because of prolonged standing. See, when you use public toilets, you soon you enter into the public toilet, you will get a puncture smell. So this puncture smell is mainly due to the ammonia which is present in the urine. So when the when when the urine stands for longer time, it will convert this urea into ammonia. Okay, so that is the smell of the ammonia. Okay, so when the uriners stand on the prolonged status, that is the first abnormal order. Second one, a fecal smell in the urine. So what is the reason for the fecal smell in the urine? It may be due to a urinary infection. Some urinary infection may lead and it causes a fecal smell. Third one, the fruity smell. Okay, fruity smell is mainly in case of ketosis, diabetic ketoacidosis, DKA. We can have a fruity smell. We can feel a fruity smell in the urine. Fourth condition is mousy odor. Phenylketonuria. Phenylketonuria will leads to mousy smell. Then rancid jasmine. Maple syrup odor. Okay. Mainly the questions will be asked about this fecal smell or first thing is this portion. Fruity smell. Diabetic ketoacidosis. Okay. Now just see the urine's color. Just see the urine color. See, when the urine is transparent, purely transparent, if the urine is purely transparent, you can say that you are overhydrated. You don't have to drink such this much amount of water. You are overhydrated when the urine is very transparent. Okay, you don't drink that much amount of water. That is an indication. No, pale straw. It's just a pale in color. Tinge of pale is the which means you are healthy and well hydrated. Okay, pale straw. So you have to keep your urine in this color, pale straw color, and the transparent yellow. It's also says that the urine is normal. Okay, how to attain this pale straw? You're drinking 2 to 3 liters of water per day will give you a pale straw color urine. Okay, then the dark yellow urine. Why the dark yellow urine? It is fine, but you have to hydrate more because urine has been converted into a dark colored urine. Okay, if it is amber color or honey colored urine, you are dehydrated. You have to drink some water. So this is the urine status in which you can see the changes in the hydration status. Okay, just take the screenshot, guys. Now, who controls the urine volume or how the urine volumes are controlled? First one is antidiuretic hormone. Sophie, which gland produces antidiuretic hormone? Sophie,
Sir,
which gland produces antidiuretic hormone?
adrenal.
No, antidiuretic hormones are produced by your hypothalamus, post hypothalamus, and it is released by, it is not secreted by, it is released by your posterior pituitary, neurohypophysis. So there are two hormones secreted by your hypothalamus. It is oxytocin and vasopressin. ADH is otherwise known as vasopressin. Vasopressin. It presses the urine. Vasopressin. Okay, it decreases the amount of urine. Okay, that is a function of a vasopressin. In any condition, if there is an decrease or disorder in this ADH hormone, it will lead to a condition known as what is that condition, Amba? If there is a decrease in the ADH hormone, what is that disease? A disease will be caused. What is that disease? Hello, Amba. What is that disease? Amba, are you there? Amba, Priyanka.
Yes, sir.
Yeah, what is that disease condition? Guys, if you don't know the answer, kindly say I'm sorry so that I can move with that. The answer is anybody. If there is an abnormality in the ADH hormone, it will lead.
Diuresis.
Diabetes,
No,
sir.
it may leads to diabetes insipidus.
That
It may leads to diabetes insipidus. That is a condition. If the vasopressin is decreased, it may leads to diabetes insipidus. Okay, so that is the case here. So antidiuretic hormone, or which is known as the vasopressin, if there is a decrease in the vasopressin, it leads to diabetes insipidus. It is secreted by the hypothalamus and released by your posterior pituitary. Okay. Next mechanism is aldosterone. It is renin-angiotensin-aldosterone mechanism. And who produces aldosterone? Aldosterone is produced by your adrenal cortex. We have the adrenal gland we have the adrenal gland on the kidneys. So here we have the suprarenal glands or the adrenal glands. Okay, this adrenal gland is having coverings adrenal cortex and adrenal medulla, cortex and medulla. So the adrenal cortex releases aldosterone. Okay, and adrenal medulla will be producing other hormones. So these hormones will be dealt in the endocrine system. Okay, so the aldosterone, which is produced by the adrenal cortex, and it what is the function of the aldosterone? It reabsorbs sodium. Okay, these aldosterone reabsorb renin, angiotensin, aldosterone mechanism. So this RAM mechanism helps in increasing the blood pressure. Okay, so we have these angiotensin converting enzyme. We have studied this angiotensin converting enzymes. Ashwati, give me an example for this AC inhibitor.
Sir, Ramipril.
Yeah, ramipril and enalapril. Okay, fine. So those are the AC inhibitors. Now, next thing is atrial natriuretic hormone. So atrial means it is secreted by, it should be secreted from the heart, right? So the heart wall produces these atrial natriuretic hormone. It stimulates the kidney tubes. Okay, it stimulates the kidney tube to secrete more sodium. Okay, here what happens in ANH or atrial natriuretic hormone. Natri means what? Sodium, uretic and urine. So it excretes urine. Okay, it excretes urine. So the sodium will be increased here in the urine. Okay, urine sodium will be increased in the urine. In case of aldosterone, what happens? Sodium is decreased in the urine. Okay, sodium will be decreased in the urine. Why? Because there is a reabsorption of sodium. In ANH hormone, there will be an increase in sodium what excretion. Fine. See, one thing I want to say is that in kidney, in case of urea, we have secretion, then excretion, reabsorption. Okay. Excretion. What is excreta? It's a waste. So our creatinine, urea, all these things are excreted. We won't, in no case, we'll reabsorb it. That is excretion. Reabsorption means in some conditions, uh, with some problems, kidney may excrete some no wanted substances like the glucose, the albumin. So all these things will be reabsorbed from the kidney to the blood, and some things are secreted like sodium, potassium, calcium, and all those things because in if wanted we can reabsorb it. Otherwise, we can just excrete it. So that is secretion. So secretion, excretion, reabsorption, those are the three major functions of these kidneys. Okay. Now, now we have the glomerular filtration rate. What is the normal glomerular filtration rate? See, this is a kindly take the screenshot. This is important for you for the kid to understand the kidney diseases. The normal glomerular filtration rate, it should be greater than or equal to 90. Okay. 90 is the normal glomerular filtration rate. Greater than 90 or equal to or greater than 90. Okay. Okay, if if the glomerular filtration rate is started to decrease, which means your kidney is having problems with that. So mildly decreased 60 to 89. See, moderate 45 to 59. Moderately severe 30 to 45. Very severely affected 15 to 25. Now kidney failure, it is less than 15. Okay, in case of kidney failure, it is less than 15. This is a normal. Just you have to understand this. See this point, more than 90 is the normal and less than 15 is kidney failure. Okay. Now, regulation of renal blood flow. How the renal blood flow is regulated. See, heart pumps 5 liters of blood per minute, that you know that, and one fourth of the blood is to the kidneys. Okay, it goes to the kidney, which means 1.25 liter per minute. Okay, per minute the kidney receives 1.25 liters. The kidney filters and the waste is removed. Okay, see, here are some catches. Okay, just try to understand these things. See, the spelling, have you seen this? Renin. This is renin-angiotensin-aldosterone mechanism. We have renin. There is another hormone. This renin is produced by uh, your intestine. Okay. Renin. This is a local hormone produced by your intestine. Renin is a hormone produced by your kidney. Don't get confused with that. Okay. So in the macula densa, macular macular densa in the kidney. Okay, in the kidney, the macula densa senses low flow or low sodium concentration. Okay, in that condition, if the sodium is less, when the macula densa feels that the sodium concentration is less, what happens? It produces or it secretes the renin. Okay, so when the kidney releases the renin, what is that enzyme? Renin, right? So the kidney releases renin into the blood. Why kidney releases renin? When the macula densa, or simply understand like this, when your kidney understands that the sodium level in the blood is less, the kidney will produces renin. Okay, so when the renin is produced from the kidney, it will be released into the blood. Okay, when it is released into the blood, there will be an enzyme reaction, and when simply understand that when the kidney releases renin into the blood, the liver releases angiotensinogen into the blood. Okay, angiotensinogen into the blood. Hmm? Okay, so when the kidney releases, what is this? We are talking about the blood sugar controlling mechanism of the kidneys. Okay, what we have said as renin, angiotensin, aldosterone mechanism. We are going to talk about this one. So when the kidney releases the enzyme renin, when it when it understand that sodium is low, it will release renin and it will be released into the blood. When the renin enters into the blood, the liver also secretes an enzyme known as angiotensinogen. See, this angiotensinogen is in the inactive stage. Okay, this angiotensinogen is in the inactive stage and it will be present in the kidney. It will be present in the blood. Okay, so when the angiotensinogen, we have angiotensinogen 1, angiotensinogen 2, all these things. So the angiotensinogen, simply understand like there is an inactive form of angiotensinogen, the inactive form of angiotensin that is known as angiotensinogen. That's why we need an enzyme ACE, angiotensin converting enzyme. Okay, so simply understand that the liver produces the inactive form of angiotensin, okay, which will be present in the blood. Now we have the renin in the blood, the angiotensin in the blood. Okay, but angiotensin in which form? In the inactive form. We have to activate it. So the angiotensin converting enzyme in the from by the lung, it will be produced into the blood and there will be a reaction and this inactive angiotensin will cause and or the inactive angiotensin will be move forward as an active angiotensin. Okay, once again I'll say the kidneys, when the kidneys identify there is a low sodium in the blood, it produces renin. When renin is in the blood, the liver also produces angiotensin, which is in the inactive form. When the angiotensin in the inactive form enters into the blood, that is the angiotensinogen. The pulmonary areas, the lungs and its areas will produce an ACE inhibitor, ACEs, that is angiotensin converting enzymes into the blood. This will convert the inactive angiotensinogen into active angiotensin. When the angiotensin is activated, it leads to a vasoconstriction and it stimulates the adrenal cortex to release aldosterone. Okay, so when the aldosterones are released, it stimulates the sodium uptake from the convoluted tubules and the collecting ducts. Okay, and the antidiuretic hormone will also act here and increase the water reabsorption. Okay. Thus, the BP is increased, blood pressure is increased. This is known as a renin angiotensin aldosterone mechanism. Do I need to explain it once again? If yes, kindly say that. Kavya, are you able to follow? Kavya, are you able to follow, Kavya?
Yes, sir.
Okay. So Rajesh, are you having any doubt?
Yes, no, sir.
Okay. So let me explain it once again. This is very important, guys. That's why I am giving so emphasis on this. So once again, let me explain. The kidneys, when the kidneys identify there is a low concentration of sodium in the blood, the renin will be secreted by the kidney and it will be released into the blood. When it releases into the blood, the liver will identify and it releases the inactive angiotensinogen into the blood. So we have renin in the blood now, inactive angiotensinogen. The when the inactive angiotensin is in the blood, the pulmonary function or your lungs will produces ACE into the blood. That is angiotensin converting enzyme into the blood. In that condition, the angiotensinogen will be converted to active angiotensin. When the active angiotensin is produced in the blood, it will stimulate the adrenal cortex. Okay, and it secretes the aldosterone. When the aldosterone is produced by your adrenal cortex, it will increase the absorption of sodium from the this distal connected tubules and the loop of Henle's. And it also activates the ADH hormone to increase the water absorption. Okay, so this is the
സാർ ഒരു ഡൗട്ട് ചോദിച്ചോട്ടെ
sure, തീർച്ചയായിട്ടും.
സാർ ഇപ്പോൾ നമ്മളിപ്പോൾ സോഡിയം നമ്മൾ റീഅബ്സോർബ് ചെയ്തു പിന്നെ നമ്മളവിടെ എന്തിനാ വാട്ടറിൻ്റെ നമ്മൾ റീഅബ്സോർബ് ചെയ്യുന്നത് ഈ ടൈമിൽ ADH ഇങ്ങനെ റിലീസ് ആവുന്നത്
Yeah, sure. A very good question. പക്ഷേ the point is, see, what Ashwati had asked is that if sodium is reabsorbed, why the water is again reabsorbed? See, simple answer, simple explanation for that is if the sodium is just reabsorbed from the urine, it will increase the sodium level of the blood. But we just doesn't need the sodium level to be increased. We want the blood pressure to increase. For that, we need plasma expansion, or we have to increase the volume of the blood. In order to increase the volume of the blood, we need the water. So that is one explanation. Second is that if we are simply absorbing the sodium, it will leads to hypernatremic condition. Okay, the specific amount of hypernatremia should be, or the specific amount of sodium should be maintained throughout the blood only when the water is absorbed. See, actually, think a condition like this. If you are just taking a glass of water, okay, and you are just adding salt into that, you when you drink it you can feel the excessive level of sodium into that, right? So what will you do to neutralize it? Or if you want to give that glass of, if you want to share that glass of water to your friend, what will you do? You will add sodium into that and you will add water into that, so that the taste is neutralized, right? So what we need here is to increase it. Our aim is not to reabsorb the sodium. Our aim is to restore the normal blood pressure, right? So in that condition, along with the sodium, the water should be reabsorbed so that the blood pressure is maintained. Otherwise, what happens if only sodium is reabsorbed? What happens? It may lead to a hypernatremic condition. Okay, it won't increase the sodium. It won't increase the blood pressure. It will just increase the serum sodium level. Got it, Ashwati?
Yes, sir.
Okay. Now, now we have the kidneys, ureters, and bladders, and urethra. Okay. Now, this is a urinary bladder. So we have ureter, bladder, rugae. Why these rugae are there? Ru Due to the presence of rugae, we can accommodate more urine. Okay. Uh, Kavya, what is the cell? What is the epithelial cell which is present in the urinary bladder? We have discussed this. What is the epithelial cell which is present in the urinary bladder? Kavya, do you know that? Or Sophie will answer it. Sophie, you know that? Hello, Sophie. Okay, Rajesh. Nobody is answering. Rajesh, what is the cell? What is the epithelial cell which is present in the urinary bladder?
Urothelium.
What?
The
What?
squamous epithelial cells.
No, dear. No, dear. It is not squamous epithelial cell. It is transitional epithelial cells. My dears, kindly study. You guys are not studying. See, being a teacher, I can just take classes. Okay, it is you are all grown up adults. I cannot treat you like how I treat the students in the college. You all are grown up adults. You are all working professionals. So it is your responsibility to study. I can just take classes. I won't say study. It's your responsibility. Now the urinary bladder. See, the peritoneum will be here. Okay, dextrosor muscle. Okay, dextrosor muscle. It is in the urinary bladder. Kindly understand this muscle. Kindly study this muscle. It is there for your exam. So dextrosor muscle on the urinary bladder. Okay, what is trigon? Trigon is this triangular space. Okay, that's known as a trigon. We have what urethra, external urethral orifice and the internal urethral orifice. This external urethral orifice we can control it, and this we can control. Okay. And we have the urethral opening. So this urethral opening continues. This is the urethral opening. Okay. Now the parts of the urethra. The parts of the urethra. The urethra is 4 centimeters in length, and it is in the pelvis. It is having three parts. No, just leave all those things. No questions will be asked. It is just 4 centimeter. Urethra is 4 centimeters in the. Now, see, I just want you to understand when a transplanted kidney is kept, it is kept in the pelvis. Okay, we won't take out these diseased kidneys. Okay, no, diseased kidneys won't be taken out, but a new kidney will be kept in the pelvis, renal pelvis, by taking these arteries and veins from this area. See, okay, no kidneys will be removed. So this was all about the basic anatomy and physiology. Anybody is having any doubt on this?